Thank you for joining us for this special series of This is Getting Old. Sponsored by the Health and Aging Policy Fellows Program, Capstone Conversations is brought to you by Melissa B., PhD, in collaboration with the George Washington University's Center for Aging, Health, and Humanities. Welcome to This is Getting Old. I'm your host, Melissa Batchelor, and today we're going to be talking about learning from what we've lost, protecting long-term care residents and staff. And I'm joined today by Cinnamon St. John and Toby Edelman. So welcome, ladies.
Thank you.
And so we'll start with some introductions. So maybe Cinnamon, tell us a little bit about yourself, and then Toby, do the same.
Great. So hi, I'm Cinnamon St. John. I'm a 2019-2020 Health and Aging Policy Fellow through the American Political Science Association. And I'm currently placed with the Center for Medicare Advocacy. And outside of the fellowship, I'm the Associate Director of the Hartford Institute for Geriatric Nursing at NYU.
I'm Toby Edelman. I'm a senior policy attorney with the Center for Medicare Advocacy in Washington, D.C. I helped found the Washington, D.C. office in January 2000. And before that, I worked at an organization called National Senior Citizens Law Center. Now it's Justice and Aging. And I've been doing nursing home advocacy on behalf of residents in Washington, D.C. since 1977.
Okay,
Long time.
Lots of experience then. So Cinnamon, why don't you tell us a little bit about your Health and Aging Policy Fellowship, kind of what brought you to the fellowship and how you ended up at the Center for Medicare Advocacy.
Okay,
and
great.
to Toby in particular.
So the Center for Medicare Advocacy is actually my second placement. And my health and aging policy journey began on Capitol Hill. I was placed with the Senate Special Committee on Aging with Chairman Susan Collins. And that was a great experience. One of the highlights was being able to lead the preparation for their annual Alzheimer's hearing. And it was exciting for a couple of reasons. First, just the work was great. It really tapped into some of the skills I developed as a former television news anchor and reporter. So I researched the issues, I identified potential witnesses, and I helped write the big hearing memo. And on a personal note, for many years, my mother had suffered from Alzheimer's disease. So unfortunately, she passed away in May, but the work I did on that hearing was very close to my heart. So the hearing was set for March, and unfortunately it had to be canceled due to the pandemic. So we're entering kind of phase 2 of the work I did on the Aging Committee. The committee at that time focused all of its energy on COVID-19 and understanding all the aspects of it to prepare for its May virtual hearing. And they asked me to research how COVID-19 impacted nursing homes. And as you can imagine, what I found was devastating. So at that time in May, 28,000 residents and staff had passed away due to COVID, and that was approximately 30% of the COVID-related deaths in the nation. So now 6 months later, we're at a point where those numbers have skyrocketed. We're at 84,000 nursing home residents and staff dying through COVID, and that number is about 38% of the nation's COVID-related deaths. You know, other issues that were showing at that time were, and still are, the racial and ethnic minority disparities, and also the social isolation issues that came from the nursing home lockdown. So it was really through my work and research on how COVID was impacting nursing home facilities that my passion for human rights and justice, and specifically elder justice, was rekindled. And when I had the opportunity to work with Toby Edelman at the Center for Medicare Advocacy, it was an opportunity that frankly I couldn't turn down, because honestly, she is an icon in the world of nursing home advocacy. She had a hand in crafting the Nursing Home Reform Act in 1987. And that Reform Act is important on many levels, and I'm going to let Toby talk about that because she is the expert. But one thing I'd like to highlight is that out of that came the Nursing Home Bill of Rights, and that established basic rights that nursing home residents have. And these are rights that we all share and have, such as being able to welcome or refuse residents, being able to exercise self-determination, being treated with dignity, having the ability of free communication, and being able to partake in, resident and family gatherings. So while those rights have currently been curtailed due to the emergency that we're in right now, and I understand that, I think it's really important that we still hold and honor the fact that these rights exist and that at some point we do need to return back to them. So I ran across a quote from Eleanor Roosevelt, who helped draft the Universal Declaration of Human Rights. And she said, "Where, after all, do human rights begin? In small places, so close to home, so close and yet so small that they cannot be found on maps of the world. And yet they are the world to individuals." And so Toby has spent the majority of her career fighting for the rights of people in nursing homes. And it is a true, it's a true honor to be able to learn from her.
Well, the feeling is mutual, Cinnamon. Let me tell you, you are the fastest learner I've ever met, and you have just picked up these issues and in your heart, not only in your intelligence, but in your heart. And it's been just such a delight to work with you these few months. Just been a tremendous pleasure. I would say that what it's like to be working on behalf of residents in Washington means talking to a lot of people all the time. Spend a lot of time on the telephone talking to mostly advocates, but frequently as well families who are calling about problems and concerns they have. So I think listening and trying to understand what the real problems are, what is going on, and then from the problems try to come up with solutions. So I think it also, the work that I have done involves a lot of reading, trying to keep up with all of the federal and state reports, the official reports, the newspaper reports, articles, whatever we can find about what's going on, to know the best of the best and the worst of the worst, so that we could get the better practices and make them universal. And then I think the third thing is that I understand it's important to work in groups. I work very closely from the very beginning of my work in 1977 with the National Citizens Coalition for Nursing Home Reform, which is now called Consumer Voice. It's important to work with others, and I think in a few moments we'll talk about the nursing home reform law, how that was created in large part by the advocacy organization pushing for implementation of a report by the Institute of Medicine. But working with lots of people from different perspectives is really critical for trying to get improvements in the lives of nursing home residents, because advocates are a small group and we're fighting a very large and powerful industry. And so it's important to get lots of people working on the same side together to the extent we can.
So, Toby, how did you develop an interest in working and advocating for nursing home residents?
Well, I started with an interest as being an attorney for poor people. I went to law school in order to work for legal services, and that's what I did. And the National Senior Citizens Law Center was a support center. Originally, I worked in a neighborhood office where clients would, climb up the stairs to our office and come talk about their landlord-tenant problems, a lot of consumer problems. But I felt doing day-to-day work was difficult and frustrating, even though I knew every day I had done something and helped somebody, gotten a bill thrown out or kept somebody in their home, got improvements made in their apartment. It would be the same clients month after month because the landlords weren't really fixing the problems. So the tenants had the same problems. We had the same clients repeatedly. And I wanted to work on more systemic change. And so I went to the law center, which was a support center. And that means we were supposed to work with local legal services attorneys, help them become the experts in our area. So the first thing I actually did when I went to work at the law center in 1977 was go to Cleveland and live with a legal services attorney and his family. Left my husband here in Washington to go do that for a week because we had a really important case called Fusey v. Manor Care, where the nursing home was kicking out all of the residents who were on Medicaid who had not been private pay for 2 years. And so I just got right into it from the beginning of dealing with a real case, real clients, and the real advocates that I've spent the next 40 years working with. It was a great introduction to the field.
Okay. So, my background's also in nursing home care. It's the only place I've ever actually worked. So I'm one of those nurses that's actually never worked in a hospital. So let's talk about, the fact that even though nursing home residents and staff only account for about 8% of the cases of COVID, they account for 38 to 40% of the deaths. And you had mentioned 84,000, residents and staff. So let's talk about how we got there.
So I think tackling these issues around nursing homes, it's challenging, right? Because one, there are many issues that need to be addressed all at the same time. And two, these issues are wide ranging. So, they're from the federal level with supply chain challenges that impact PPE and testing supplies, to issues that are within the nursing home facilities, such as staffing and infection prevention and control measures, even down to the built environment of the nursing home facilities, such as the congregate living environment, where older frail adults are living very closely to other older frail adults, and then you have staff going in and out of rooms. But suffice it to say that there were cracks in nursing home facilities before COVID-19, and the pandemic has only exacerbated those issues. So there are three that I'd like to quickly talk about. One is staffing, two is ethnic and racial minority disparities, and three is infection prevention and control measures. So when we take a look at staffing, Charlene Harrington out of UCSF wrote a great paper about nursing staffing and coronavirus infections in California nursing homes. And she identified that there were inadequate staffing levels in nursing homes before COVID. And she concluded that nursing homes with both low nursing staff levels and low total staff levels appear to have left residents open to COVID-19 infections. So let's take a look at why there are low total staff numbers. And one of the big issues is pay. PHI came out and has said that 13% of the direct care workers in nursing homes are at the poverty level. And so they analyzed the hourly wages from 2009 to 2019, over 10 years. And in 2009, direct care workers in nursing homes made on average $13.39 an hour. And in 2019, they made $13.90 an hour. So we're talking over 10 years, the hourly rate only increased by approximately 50 cents. So when you go to a vending machine, it costs about $1.50 to get a Coke. And so the increase in their hourly wage can't even cover a can of Coke. And when you look at what that low pay is compensating for, we're talking about jobs that are physically and emotionally taxing, jobs where there are high rates of, on-the-job injuries, jobs with low training to help them, they don't have enough training to help them navigate this terrain. And they're having issues just keeping their own safety. So in accessing PPE, David Grabowski out of Harvard said that during the pandemic, nursing home workers have one of the most dangerous jobs out there. And on top of that, they have very low benefits. So all of this package for $13.90 an hour. And I think it's important to keep in mind that before COVID, the long-term care industry was having a hard time keeping workers. There were more people leaving the industry, more direct care workers than those entering. And they were actually choosing unemployment instead of staying in their job. So that's a huge issue that needs to be rectified. And a second issue is the racial and ethnic minority disparities. There are, as we know, widespread disparities in nursing homes, but those that people with racial and ethnic minorities end up in nursing homes that have inadequate nursing staffing, facilities that have limited financial and clinical resources, and also facilities that have more care deficiencies. So this was before COVID. And now we're seeing evidence that in nursing homes that care for disproportionately more racial and ethnic minorities, they are having more confirmed cases and deaths of COVID-19. So the Washington Post has reported that in homes where at least 70% of the residents are Black, they have a death rate that is about 40% higher than homes where the majority are white residents. So third and finally, another issue that existed before COVID, it centers around infection prevention and control measures. Now, Toby is the expert here. She's dedicated a lot of her work on this, so I'm going to let her go into that more deeply. But quickly, According to the General Accounting Office, infection prevention and control deficiencies were the most common type of deficiencies cited in nursing homes before COVID. And some of these deficiencies, going back to 2013, 7 years ago, were situations where staff didn't know how to properly wash their hands. They failed to use preventive measures during infectious disease outbreaks, such as using masks and PPE properly, and isolating sick residents. So clearly, all of these measures are critical and should be in place before something as catastrophic as COVID-19 swept through the nation.
That was a brilliant analysis of what is going on, and I agree completely about this. I would say, with respect to the staffing issue, the CDC wrote a report about the Life Care Center of Kirkland, the Seattle nursing facility where the first outbreak was seen. And one of the points that CDC made early on in its weekly morbidity and mortality report is that staff was going from facility to facility and bringing, this is when they were contagious but asymptomatic. People weren't doing this deliberately, but they were spreading the disease all throughout the Seattle nursing homes. The reason people work multiple jobs is, as Cinnamon said, they get a minimum wage or just above the minimum wage. One of the briefings that I participated in, one of the other speakers was a nurse aide in Chicago who's been a nurse aide for 10 years. Seemed like a very devoted person. He got interested in the field because he had taken care of his grandfather at the end of his grandfather's life. And he saw his main purpose is trying to bring a smile to people's faces. He was a very, very sweet and loving man who actually moved out of the family home because he's concerned about if he got COVID-19. He had still not been tested. This was in May. He had not been tested in his facility, and his grandmother was in the home, and he did not want to give it to her if he got it. He's making $30.90 an hour. That is not a living wage for people. And so they work multiple jobs. That's a very serious problem. And it just can't go on like that. But we do have a bright spot later. The other point about infection control, as Cinnamon said, it's very common. It's been the #1 deficiency. And CDC says infection control for COVID is identical to infection control for any other infectious disease. #1 problem in nursing homes, within the #1 problem of infection control, is hand washing. Staff don't wash their hands sufficiently or correctly. And I think it's largely because there aren't enough of them. The direct care workers are rushing to do all the tasks they have to do. And so they cut corners. And hand washing is probably one of those things they don't do. But CDC says hand washing, disinfecting equipment between residents, that is absolutely essential. Isolating residents who are contagious or who appear to be contagious, appear to have the disease. These are using PPE correctly, consistently. These are problems that have been cited for years, and they're still there. But as the GAO said in the report that Cinnamon referred to, even though it's the #1 deficiency cited in huge numbers of facilities, 80% of facilities in that 5-year period, and nearly half of them in multiple years, what the GAO also said is there's almost no enforcement. Nothing happens to facilities that don't follow infection control problems. So even though they might be cited, that means the government might say, you have a problem in this area. In more than 90%, 99% of the cases, there is no financial penalty. And with this industry, that means there's just not a lot of correction. And this really hit us last week when we read about a nursing facility in Kansas, 62 residents, all of them infected with coronavirus and staff, and 10 residents have died already. When we looked at the record of this facility, it had been cited with an infection control deficiency just in May 2020, at the highest level called immediate jeopardy. We see no record of any penalty, and here we are 5 months later, everybody infected. So these rules matter, and they have to be enforced. The words of the law that govern nursing home practices, the nursing home reform law that was enacted in 1987, the words are very good on paper. But if they aren't followed, if they're not implemented, if they're not enforced, if violations don't lead to a real penalty and a real change in practices, then they're just words on paper, and it's not enough. So we have had a lot of difficulty with this. The nursing home industry we know now is mostly for profit, and more of the facilities are run by real estate investment trusts, not by healthcare professionals. The motivation they have is money, and if they're not penalized, they don't have to pay a financial penalty. Too many of them will just ignore the problems. See what happened in the Kansas facility. It's very frightening, and it was avoidable. That should not have happened.
Yeah. For it to be the most heavily regulated industry next to nuclear power plants, it's amazing that we still have this level of issues. And if there isn't a regulation or a financial penalty, it just doesn't get the ownership's attention to make the change. And when you're the nursing assistant at the bedside, you have very limited power about how you change the culture of your nursing home. And so we have facilities that do a really, really good job, and then we have all the way down to facilities that don't. So now let's talk about what are some of the things that can be done moving forward to make sure that COVID doesn't spread through nursing homes.
So Melissa, we've talked a lot about wide-ranging issues, and there's a lot to be done. And the good news is there's a lot that can be done. I'm currently working on a report. I'm midway through that will be ready in January that's taking a look at this very issue. And there are two aims of my report. And the first one is identifying best practices in nursing home facilities. And the second one is really examining the notion of, is geography destiny? Because right now, the notion out there is really that if COVID enters a community, it's basically going to get into a nursing facility, at some point. And my thesis is that while it increases probability, there are things nursing homes can do to keep COVID out. I'm analyzing facilities that are in the same geographic region. And like you said, there's a range. So I'm looking at those facilities that have done a great job at keeping COVID out, either altogether or mitigating it quickly, and those facilities that have not been so successful. And, in my analysis, I'm both building upon existing research, because there's a lot of research out there, but I've also created a survey that I'm about to send out and hopefully, analyze those facilities on a facility by facility basis and kind of get inside the doors and see what the mindset is. But so far through my research, what I have found is that there seems to be this X factor, and that X factor is proactive leadership for those facilities that have done a great job at keeping COVID out. And what I mean by proactive leadership, it's both acting quickly and decisively, but also implementing a holistic and respectful approach to those people impacted by COVID or by in the facility. So I've discovered at this moment about half a dozen actions that successful nursing homes implement. So when I talk about taking quick and decisive action, oftentimes they start planning their preventative measures well before COVID has hit the community. They develop an operational plan and they start stockpiling PPE early. They also have strict standards for staff who both enter the work facility, but also when staff are off duty, asking them to curtail their socialization and personal life a bit. They cohort residents that were infected, as Toby mentioned, but they also care for the mental well-being of residents. They ensure that staff visit the residents while they're in lockdown to help control, the social isolation that comes about. They have great communication with staff, with residents, and with families of residents. And they're not afraid of these candid, uncomfortable conversations, because as we know, tensions are high and families are worried. These leaders were often able to stand their own ground and explain to families what's going on and why they need to implement these strict measures. And at the end of the day, they're able to kind of walk them through this scary time. But finally, the leadership that I've been seeing is self-awareness and humility to know when their plan is not working, and the flexibility to develop a new plan. One nursing home owner in Connecticut realized that once asymptomatic spread became an issue, that his plan to check staff for symptoms upon entering to work wasn't going to work out. So he was really creative. He actually offered bonuses for staff to live in RVs that he had parked on his facility's lot. Another example of great leadership is what we saw with the Maryland Baptist Aged Home in Baltimore. So this facility serves predominantly low income, older Black and Hispanic populations, and has been able to keep COVID out. And the director of this facility acted fast and early. He started laying his plans back in February and ordered PPE 2 weeks before COVID entered the Baltimore community. And he hired a full-time infection control nurse 10 years ago. So talk about preparation. He also had strict standards for staff, but additionally, he cared for staff and made sure that he cared about their mental well-being. And in doing so, he created a respectful relationship, and the staff became, or were, very invested in their work and invested in the residents. And PHI has said that caring, committed relationships between direct care workers and clients are at the heart of quality care. Another instance, there was a nursing home in Oregon that was only 20 miles away from a facility that had a major outbreak, and they were able to stave off cases by preparing for the coronavirus outbreak before it actually entered the United States. So I'm really excited to see what kind of data comes back from these surveys I send out and see what kind of analysis we can have.
Those things make a tremendous difference. I mean, there are facilities that, according to the research that we read, of all the facilities in Connecticut, the facilities that had 20 minutes more of registered nurse time had fewer cases and fewer deaths. So the things that we have been saying for decades, we need better staffing levels, more registered nurses, that's true. And it makes a difference. It would absolutely make a difference in residents' lives. I think what we're hoping for, Melissa, is that the only bright light in this horrible, horrible pandemic is that there's more attention now to nursing homes than we've really ever seen before. And some of these issues that we have been talking about, that advocates have been talking about for decades, Charlene Harrington's work for decades on staffing levels, might actually get more attention. And we have a couple of positive things about staffing. New Jersey hired the Manat law firm to do an analysis of what happened in New Jersey. Why were there so many deaths in nursing homes? What was going on? And Manat wrote a really fascinating report with a huge number of recommendations, which are now making their way into state law. New Jersey has already passed 2 laws about staffing. One, increasing the aides' salaries by $3 an hour at least. And just this past week, I saw over the weekend, they passed a new staffing ratio bill. So I've sent that to Charlene to make sure that that's really the good numbers, but always want to clear that with her. She is our expert on this issue, but they are responding. That is a positive sign. The other positive sign in staffing was a report that was released a couple of weeks ago by the National Association of Not-for-Profit Nursing Facilities, Leading Age. This report found that paying workers a living wage, not minimum wage, but a living wage, would reduce staffing shortages in facilities, reduce turnover, improve quality of care for residents, and reduce workers' reliance on public benefit programs that are based on need, like Medicaid. But I think what was most fascinating to me about that report was Leading Age's finding that paying a living wage would likely pay for itself just by improving care for residents. Their report basically says we don't need to pay facilities more, we just need to make them spend it differently. And I've reached out to one of the lobbyists at that association, and we've agreed that next year we're going to work together and go to Capitol Hill and talk about this report and the importance of having a living wage. So that's really wonderful. I think the second big change we need is change to the enforcement system, and we need to restore some of the stronger enforcement practices that the Obama administration put in place slowly, because enforcement's always been the weak link in the nursing home reform law. But there were some positive changes made that have been undermined by this administration, current administration. And so we need to restore enforcement. But I think there are two additional things that we need to do. And we need to use this increased attention on nursing homes to get two other major changes. First, we need better controls over who is allowed to own and operate nursing homes and manage nursing homes. That seems critical because now there seems to be very little control at the state level and zero control at the federal level. Federal government will give certification and allow facilities to get Medicare and Medicaid reimbursement if they're licensed. And the licensure rules are not strict enough. They are not really assuring that good owners are taking care of this, are providing care to residents. But the second really key thing is that we need to control how facilities spend the public reimbursement they receive. And again, New Jersey has just passed a law from one of the Manat recommendations saying that facilities must have a direct care ratio. They must spend money on care, not on excess profits and overhead and administration. So of course, implementation of that law will be key, but it is the first time we have had a state say, we're going to control how the money is spent. We're not just going to give you money and let you do whatever you want with it. We're going to say a certain percentage must be spent on care of residents. And that might make a really big difference. These four changes, staffing, enforcement, who owns facilities, and how they spend their money could really make a difference and improve care for residents. We should never have this pandemic again, anything like it.
Right, and we can hope that we won't. Yeah, so Charlene Harrington was actually on the podcast a couple of weeks ago. We talked about more professional nursing in nursing homes. And so I think the leadership and management training of professional nurses, and actually, I think that most people aren't aware of the fact that that right now they're only required to have a registered nurse in the building 8 hours a day. And so so that makes a big difference. And then the National Academy of Medicine announced 2 weeks ago that they're going to, for the first time since 1987, have a new committee look at patient safety and quality in nursing homes to update that report and hopefully make some of these same recommendations that you're making for policy changes. So speaking of future work and next steps, Cinnamon, what do you think's next for you, and how has the fellowship influenced your career path?
Sure. Well, one of the beauties of a health and aging policy fellowship is that they really wanted us to craft our own experience. And I've been able to expand my knowledge on policy formation in what I call an inside out, outside in perspective. So through my 2 placements with the Senate Special Committee on Aging and the Center for Medicare Advocacy, I've been able to gain this perspective of this conversation around policy formation and kind of tapping into what Toby said earlier about working in groups. Each side, lawmakers and advocacy groups and special interest groups, inform and influence each other. And so the question I've been trying to decide is, what side of the conversation do I want to be on? But one thing is for sure, my commitment to human rights and elder justice will definitely continue. I'd like to hone my knowledge more while I work full-time in the policy realm. I would also like to go to law school part-time to really flesh out my knowledge there. Recently I was able to hear one of my personal heroes, Brian Stevenson, speak, and he's the founder of the Equal Justice Initiative. And he said in this talk, a great society does great things for children. And I thought, yes, absolutely. But a great society should do great things for its older adult population. And unfortunately, there's a lot of work to be done. And, I'm going to jump in, and I've been lucky in this past year to work with 2 national advocates for these individuals.
So Toby, what about future work for the Center for Medicare Advocacy? Next steps for you?
Well, I'm way past retirement age at this point, but I am going to keep going for a while. And I am thrilled that I've had the opportunity to work with Cinnamon, because she is, you can hear, so brilliant and knowledgeable and committed. And I'm just delighted to help help form and shape the next generation of advocates. It's a wonderful opportunity, and I'm really thrilled about it. Thank you.
Great.
Thank you, Toby. That was great.
Yes. And, and I agree with you, Cinnamon, when, which is why, the podcast is called, moving towards an age-friendly world, because when things are age-friendly, they're friendly for everyone. And, older adults, I do think, are the one group that kind of gets left behind with, having strong advocates. So thank you both for all the work that you do and have done and are going to continue to do. And thank you for joining me today.
Thank you for having us. This has been great.
Yes, wonderful. Thank you.
Great. Thank you.
Thank you for joining us for this special series of This is Getting Old. Sponsored by the Health and Aging Policy Fellows Program, Capstone Conversations is brought to you by Melissa B., PhD, in collaboration with the George Washington University's Center for Aging, Health, and Humanities. Thank you for joining me today for This is Getting Old. If you'd like to know more, you can subscribe to my YouTube channel, and if you have any questions or a related topic you'd like to hear from me about, just let me know. Thanks.